Welcome back to the deep dive. Today we are tackling one of the most structurally complex regions in the entire body. We're looking at chapter 38 of Gray's
You
Anatomy.
certainly are. We're heading deep into the infratemporal and pterygopalatine fossae, and of course the temporomandibular joint, the TMJ.
In this area, it's not just a collection of parts. It's more like I don't know, a dense three-dimensional neurovascular highway. It's a real challenge to visualize.
It's what students often call a nightmare, and for good reason. Think of it as a traffic control center for the skull. You have major nerves, blood vessels, powerful muscles, all packed into these incredibly tight quarters.
A traffic control center. I like that. So our mission for this deep dive is to unpack that puzzle for you.
Exactly. We wanted to find the boundaries, map out the contents, and then really connect it all to the movements and the clinical side of things. The goal is for you to be able to build a mental map of this area without, needing a diagram right in front of you.
Okay, let's start mapping this traffic control center then. Let's begin with the main staging ground, the infratemporal fossa, or ITF. Where exactly are we?
All right, so the intertemporal fossa is this deep, kind of irregular space. It's located deep to the ramus of the mandible. And the most important thing to get right away is that it's not a closed box.
It's an open space.
It's a very open space. It communicates widely. You can almost think of it as a vertical corridor.
Okay, a corridor. So if we're standing inside it, what are the walls?
Right, so the front wall, the anterior wall, is the back surface of your maxilla. The side wall, the lateral one, is the inside surface of the mandibular ramus.
And the medial wall, the one facing inward.
That would be the lateral pterygoid plate, part of the sphenoid bone. And then a bit further back, you're right up against the pharynx.
Got it. And the roof must be where it gets really complicated because that's the base of the skull, isn't it?
It is. The roof is mostly the infratemporal surface of the greater wing of the sphenoid bone. And this is so critical because that's where the holes are, the foramina that let everything pass into the middle cranial fossa.
You mentioned it's a hub. It has to connect to everything. What are the major highways leading out of this fossa?
Well, there are four really critical ones. Superiorly, it's wide open to the temporal fossa.
Okay.
Anteriorly, it connects right into the orbit through the inferior orbital fissure. Medially, it links to the very dense pterygopalatine fossa. And then, most importantly for neuroanatomy, it goes up into the middle cranial fossa through two famous holes, the foramen ovale and foramen spinosum.
So that sets the stage for everything passing through. Who are the residents here? What are the key nerves, muscles, and vessels packed into this intersection?
The muscles are dominated by the two pterygoids, the lateral and medial. But the real heavy hitters are the nerves. You've got the mandibular division of the trigeminal nerve, V3, with all its branches. And then you have the chorda tympani, the otic ganglion. And for the vasculature, the maxillary artery is the main supply line. And crucially, the pterygoid venous plexus.
Okay, that plexus, that's where the clinical side gets really urgent, right? It's not just a bunch of veins.
Not at all. It's this dense network of big veins. And the reason it's so important clinically is its connections. It communicates with the facial vein on the surface, but it also connects deep, right into the cranial cavity with the cavernous sinus.
So it's a direct pathway for infection.
It's a high-risk pathway. An infection from, say, a dental abscess can track directly back into the skull. It's a huge deal.
That connection really elevates the stakes. Okay, let's look at the bones that create this space. It's really all about the sphenoid and the mandible.
The sphenoid is the foundation. It's the keystone. Its greater wings have this ridge, the infratemporal crest, that divides the bone into its temporal and infratemporal surfaces.
And on that infratemporal surface, you have those three legendary holes every student dreads learning.
Exactly. The V2 and V3 highways. You have the foramen rotundum for the maxillary nerve, V2, and a posterolateral to that is the big one, the foramen ovale, for the mandibular nerve, V3.
Right.
And the smallest of the three, the foramen spinosum, which lets the middle meningeal artery pass through. These three are the main transfer points between the cranium and the face.
Okay, now for the moving part. The mandible. What are the key features we need to know?
Well, on the body, you have the mental foramen, where the mental nerve exits. That's the spot for local anesthetic. Internally, the mylohyoid line defines the floor of the mouth. But up on the ramus, you have the muscle attachments, like the coronoid process for the temporalis, and of course the condylar process for the TMJ itself.
But there's that little sharp spine that's so important for dentists.
Ah, the lingula, yes. It's a tiny spine that overlaps the mandibular foramen, which is where the inferior alveolar nerve enters the bone. It's the key landmark for an inferior alveolar nerve block. You aim for the lingula.
Now, this is where it gets really interesting for me, how age changes this whole picture. Let's talk about the mandibular canal.
Right, so in someone with a full set of teeth, that canal with a nerve is safely buried deep in the bone. But in edentulous patients, people who've lost their teeth, the alveolar bone resorbs. It shrinks away.
So the whole structure just diminishes, and that exposes the nerve.
Precisely. The atrophy is so significant that the mandibular canal and the mental foramen can end up sitting right on the superior border of the jaw. The safety margin is gone.
Wow. So a routine procedure like a dental implant suddenly becomes a high-risk neurosurgical event.
That's a perfect way to put it. The risk of nerve damage becomes extremely high.
That dynamic change leads us perfectly to the joint itself, the TMJ. What makes this joint so unique?
Well, the biggest thing is its lining. Most synovial joints are lined with hyaline cartilage. The TMJ's articular surfaces are lined with fibrocartilage.
And that's a huge difference.
A huge difference. Fibrocartilage is tougher, it's more robust, and has a much greater capacity for self-repair.
And what about the load-bearing surface? It's not the thin roof of the skull above it, right?
No, absolutely not. The roof of the glenoid fossa can be paper thin. The primary load-bearing surface is the articular eminence, that thick ridge of bone anterior to the fossa. All the force goes there.
And that force is managed by the articular disc, which divides the joint into two separate compartments.
It does. And that disc is amazing. The central part is a vascular, non-innervated, dense, fibrous tissue built to be squashed. But the back part, the posterior attachment, is the bilaminar zone. It's full of vessels, nerves, and elastic fibers.
Why is that elastic attachment so important?
Because when you close your mouth, the condyle slides back. Those elastic fibers actively pull the disc backward with it, keeping it perfectly centered on the condyle, ready for the next opening movement. It's a self-centering mechanism.
Okay, let's walk through that opening movement. How do we get that 35 to 50 millimeters of gape?
It's a two-act play. Phase one is pure rotation. It's a hinge movement, and it happens in the lower compartment, between the condyle and the disc. That gets you your first 15 to 25 millimeters.
Just enough for talking, maybe a small bite.
Exactly. But if you want to open wide, you have to engage phase two, translation.
The sliding
The sliding part. Here, the condyle and the disc slide forward together down that articular eminence. This happens in the upper compartment. Without that slide, you can't open your mouth fully.
And ligaments are controlling this whole choreography. How do they do that?
The main one is the temporomandibular ligament. As you start to rotate open, that ligament gets taut really quickly. And that tension acts like a fulcrum, mechanically forcing the condyle to start sliding forward.
So the ligament itself actually triggers the second phase of movement.
That's right. It converts rotation into translation. It's a brilliant piece of engineering.
But sometimes that system fails, and you get that click or a pop. What's actually happening mechanically when you hear that click?
That's usually what we call disc displacement with reduction. The disc gets pulled a little too far forward. The click you hear is the sound of the condyle finally popping back onto the disc as you open.
Reduction, meaning it snaps back into place.
It snaps back. So after the click, you can usually open fully. The real problem is disc displacement without reduction.
Where it gets stuck.
It gets stuck. The disc stays anterior, and it physically blocks the condyle from sliding forward. That's when you get severe, painful, limited opening.
Okay, let's talk about the movers then, the four muscles of mastication. They're all innervated by the mandibular nerve, V3.
Right. You have the three main elevators, or closers. Temporalis is a powerful elevator, but its horizontal posterior fibers are the only thing that can pull the jaw straight back at traction. Masseter is just pure power for closing. And the medial pterygoid mirrors the master.
But the lateral pterygoid is the really complex one. It's horizontal.
It's the most specialized, for sure. When both sides contract, you get protrusion. The jaw slides forward. When only one side contracts, the jaw swings to the opposite side. That's the grinding motion for chewing.
And here's the part that always surprises people. The counterintuitive action of its two heads.
Ah, yes. This is a fantastic insight from EMG studies. The lower head contracts when you open your mouth. That makes sense. It pulls the condyle forward for translation.
Okay.
But the upper head contracts when you close and clench your jaw.
Wait, why would a muscle that helps open the jaw contract when you're closing it?
To protect the joint. The big closing muscles pull the condyle backward with a lot of force. The upper head contracts to brace the condyle, to keep it stable against the articular eminence. It prevents the joint from being crushed backward into that sensitive bilaminar zone.
Wow. That is an incredible stabilizing mechanism.
It is. It's split-second reciprocal innervation, just to chew.
Okay, let's finish our tour with the neurovascular highway, the maxillary artery.
It's the main blood supply. It comes off the external carotid and travels right through the ITF. As it does, it gives off some huge branches, like the middle meningeal artery going up through foramen spinosum and the inferior alveolar artery going down into the mandible.
And its final destination is that tiny space, the Pterygopalatine Fossa, the PPF.
Exactly. The PPF is a tiny inverted pyramid that's basically just a compact neurovascular conduit. It's packed with the end of the maxillary artery, the maxillary nerve V2, and the pterygopalatine ganglion, which controls secretions for the lacrimal gland, nose, and palate.
And there's a clear spatial rule here for surgeons, right?
There is. Endoscopically, the blood vessels are always anterior to the nerves. The artery and its branches are in front, the nerve and the ganglion are behind. It's a critical landmark.
Finally, let's go back to the mandibular nerve, V3, specifically the lingual nerve and its vulnerability.
This is a huge clinical alert. The lingual nerve runs very close to the medial side of the mandible. Right at the third molar, the wisdom tooth, that nerve is only about 3 millimeters below the crest of the bone.
3 millimeters, that's nothing.
It is nothing. It's a tiny margin of safety, which is why it's so easily injured during wisdom tooth extractions, potentially causing permanent numbness of the tongue.
And to circle all the way back to infection, where does that pterygoid venous plexus pathway lead in a worst-case scenario?
Well, a third molar infection can easily spread into the pterygomandibular space.
Yeah.
That causes trismus severe muscle spasm, where you can't open your mouth.
And if it gets worse?
If it progresses and involves both sides of the floor of the mouth, it's called Ludwig's angina. And that is a true medical emergency. The swelling pushes the tongue up and back, and it can completely obstruct the airway. It's life-threatening.
That is just a stunning journey, from the simple act of chewing all the way to a critical airway emergency.
It really is. I mean, to synthesize it all,
Yeah.
the ITF is the busy hub. The sphenoid and mandible are its foundation. The TMJ is this unique self-repairing joint. And the whole thing is driven by these muscles, especially the dual-action lateral pterygoid. And it's all laced with these incredibly vulnerable nerves and vessels.
So what really stands out now is just the sheer complexity required for basic things like talking and eating. Every single movement is this perfectly choreographed sequence happening in these incredibly tight quarters.
And consider this. The bite force on the TMJ can exceed 300 newtons. That's over 67 pounds of force on that tiny surface. And the joint survives it because of its mobility and that adaptive fibrocartilage. So if nature engineered that level of dynamic adaptation just to crush a nut, what other unexpected, incredible structural safeguards might exist in other high-load regions of our bodies? Something to chew on.